My name's Kavita, and it's lovely to see so many familiar faces and names along the Brady Bunch squares. So first, we must ask ourselves, what are the goals of medicine? And there's a tradition of advocacy in medicine, yet it's generally thought to be limited to advocating for the patient at your bedside. Recently, medical education, and we just heard from the AAMC, has adopted more of a health disparities framework. And this framework acknowledges that there are numerous and complex factors that influence each patient, and that these factors are at multiple levels that are not solely within the traditional space for a physician, or even within the space for the entire healthcare system. That is, data show that social determinants of health are actually much more impactful in terms of overall health and health outcomes than what we can do within our exam rooms. As Dr. Rudolph Virchow stated, if medicine is to fulfill her great task, then she must enter the political and social life. But unfortunately, several studies have concluded that although physicians tend to endorse the idea of advocacy, not many actually engage in the activity. So learning about social determinants of health is not enough. And advocating for social change goes far beyond making charitable donations or going the extra mile for your individual patient, as lovely as those things are. The actions required for change demand a more extensive and continued commitment to health equity. It is about advancing practices and policies that support health equity. So we must understand then that equity is not only a noun, but also, and more importantly, commit to the process as a verb. So how do we do this? So first, multi-level problems require multi-level solutions. And at the individual level, we can lean into the concepts of structural competency, allyship, and accompaniment. Structural competency teaches physicians how social, political, and economic determinants of health cause illness. This approach focuses on the forces that influence health outcomes beyond the individual encounter and the concept of structural humility, so that professionals must be led by the community to solve problems. Allyship and accompaniment follow the same vein of building relationships with patients and communities, like we just heard in the past presentation. And it's really important to note that the traditional power dynamic is flipped. It is not activism or advocacy for self-serving purposes. It is about doing what the community or the patient wants and needs, not you. At the healthcare system level, that includes advocacy for local policy and operations change that accounts for structural barriers. That is true for both clinical care and in the research space as well. And at the policy level, this is about being active, getting your voice out there, but again, not just for the sake of your voice, but to amplify the voices of those that have been marginalized. That can be through media, such as op-eds, interviews. It can be through involvement with organized medicine or grassroots advocacy organizations. And it can also be through cultivating a relationship with your elected officials, or better yet, become one of your elected officials. And turning our attention from clinical practice and health policy advocacy to research, what does activism for the purpose of equity look like in the research space? I believe it is thinking about the who, what, why, where, and how. So who is on your team? What are you studying? Why are you studying it? Where are you doing your work? And how are you doing it? And how are you disseminating it? By putting sort of the traditional academic power structures to the side, and rather focusing on what patients and communities themselves need, what are their goals of care, what are their goals for your research, you'll flip the traditional power dynamic and become much more equity-centered. Thank you.